for joining us for talking Ph-positive lymphoblastic leukemia, improving outcomes of frontline treatment and mitigating relapse. In this segment, we'll be discussing the role of chemotherapy in the frontline treatment of Ph-positive ALL. My name is Katarzyna Jamieson, and I am an associate professor of medicine at the University of North Carolina, Chapel Hill. I am joined here today by my colleagues, Dr. Richard Stone and Farhad Ravandi. So chemotherapy in varying intensity has been used to treat Ph-positive ALL for decades. It produces a respectable rate of complete remissions. However, they do not last long. And historically, the only patients who were able to enjoy long-term survival were those who were able to be treated with allogeneic stem cell transplant. With the introduction of TKIs, this changed. So incorporation of tyrosine kinase inhibitors rendered conventional dose chemotherapy much more effective. Multiple regimens have been developed. However, they have been studied mostly in phase 2 trials, and they have not been compared in organized fashion. Just the best approach to, when it comes to chemotherapy and TKIs, the best approach, the best regimen really doesn't exist. In the first segment, we alluded to hyper-CVAD and dasatinib. So MD Anderson worked very hard on perfecting their hyper-CVAD regimen by incorporating imatinib, dasatinib, and then finally ponatinib. And they published widely and popularized this regimen in this country and pretty much all over the world. So many of us think of hyper-CVAD and TKI as the standard of care for treatment of Ph-positive ALL. As Farhad mentioned, the results of their studies, at least when it comes to hyper-CVAD and dasatinib, have been validated in multi-center setting by an intergroup trial, SWOG-led 0805 trial. The 3-year survival in the trial was quite impressive, of 69%. Now, in the first module that we just completed, we actually alluded we discussed which TKI inhibitor is best. And we did discuss ponatinib, which is the only TKI that is able to overcome resistance to T315I mutation. So this is the mutation implicated in most cases of progression of relapse of ALL. So it should not come as a surprise that the results of hyper-CVAD and ponatinib among the 3 hyper-CVAD and TKI regimens seem truly the best. So early on, MD Anderson reported that the complete remission rate on with that regimen reaches 100%, the complete molecular remission rate 84%, and 3-year survival of 80%. And as far as I understand, with the longer follow-up, and Farhad, you may want to comment on it, these results definitely are holding up. Is that?
Yeah, sure, absolutely. Are you talking about the hyper-CVAD ponatinib? Yes.
And ponatinib, that's right.
Yes, so I think one thing that we can talk about is lower intensity versus intensive chemotherapy plus TKI. One of the things that when I've reviewed these papers, in the past we used to lump all the Philadelphia positive ALL patients together, but I think it's very important to consider this as age groups. And of course, the younger patients are able to tolerate chemotherapy, and the older patients, when you especially move to the upper 60s and 70s, chemotherapy is not probably ideal strategy, even with TKI. So there was the very intriguing French randomized trial where they compared hypacibad plus dasatinib, if I remember correctly, versus just dasatinib and low-intensity chemo initially. And they actually showed a higher response rate in the lower intensity regimen because they didn't have the mortality associated with the intensive chemo. And because virtually most of these patients went on to transplant, this question is very important. The question actually even arises now in a younger patient. If you have a donor and you have a donor identified and you've discussed it with a patient and the patient is set to go on to have an allogeneic stem cell transplant, one could argue, why would you subject them to the high intensity regimen where you can get similar, if not higher, response rate and then move on to transplant? Of course, in the older patients where transplant is not feasible, one has to think about long-term outcomes, and their strategy that Dr. Stone mentioned, trying to consolidate with more effective regimens like antibody-based therapies, as was published by the Italian group, will become a factor that one has to think about. I think I'm going to stop here to give Dr. Stone some time to see what his opinion is.
Well, I totally agree with everything that's been said so far. Of course, we do not know how intense the chemo should be given with upfront therapy. I mean, the randomized trial that was done by the Graal group that you referred to was really in favor of limited chemo. Yet your trial that you did with SWOG and other trials has led to that become chemo, an ALL regimen plus TKI being sort of the standard, I think, around in many places. That may be changing because of the recent iteration published by the Italian group that you also referred to of dasatinib chemo followed, dasatinib minimal chemo, including intrathecal chemo, followed by blinatumomab, regardless of the PCR, of the molecular response, just giving everybody blinatumomab to eliminate those clones that might pop up with a T315I mutation. That seems to be right now the best of both worlds. You get no ponatinib-induced toxicity, yet you use blinatumomab, which is generally fairly well tolerated, to mop up the nasty clones that might arise. A lot of those patients got transplanted, some didn't. I think that's a topic for another day. So if I had to choose right now, and I don't give anybody hyper-CVAD or even mini hyper-CVAD. I give them the FOA regimen and blinatumomab and then transplant them, but that's just my view. There is a very important ongoing ECOG-led U.S. intergroup trial led by Dr. Ofran of Israel, which is comparing basically your regimen, although multiple TKIs are allowed, of dasatinib hyper-CVAD to a more FOA-like regimen, including blinatumomab if there's no MRD negativity achieved. And then there's no decision about whether or not to get a transplant. So that will be an American answer to the question about whether intensive chemotherapy is needed at the moment. In the context of no clinical trial, I strongly prefer in young and old patients for a variety of reasons. Young because they're going to get a transplant, in my opinion. Old because they're not going to get a transplant. We don't want to make them sick. I use the FOA regimen exclusively.
And the only thing I want to add to that is that, of course, in the younger patients who don't have donors or don't have a possibility of transplant, I know this is becoming less and less common because the variety of donors are available. One has to always think about, the long-term outcomes, and there one might think about the more intensive regimen plus perhaps the more effective drug ponatinib. And of course, there's also the study that has been published or has been reported by our group and hopefully soon to be published, which is combining blinatumomab with ponatinib right from the beginning. And there are a lot of points to argue for that. In oncology, in leukemia, we've always developed drugs initially in the relapse setting and found them to be effective. And once they're effective, we can move them to the front line to try to avoid future relapses. And there's an argument that if we can develop a safe combination of blinatumomab and ponatinib, perhaps with the reduced doses of ponatinib, so the cardiovascular toxicity is not an issue, maybe we can even think about a future when we don't have to have a transplant. And I think that's probably going to be the topic of the next segment.
So, yes, so we are definitely moving from, the high dose multi-agent cytotoxic chemotherapy is effective, but it is very toxic. And these days, the investigations are focusing on monoclonal antibodies combined with TKI inhibitors instead of high-dose chemotherapy combined with TKI inhibitors. Now, what is actually interesting, looking at the ALBA study, great majority of patients on that study managed to achieve a complete molecular remission by 5 cycles of blinatumomab. Patients on that study received up to 5 cycles of blinac consolidation. And however, and there was a follow-up published, I believe, not too long ago, in which GMMA group commented that those patients who were able to achieve a complete molecular remission on that study actually went on to maintain it, and they had excellent outcomes with the longer, that kind of stood with the longer follow-up. What was interesting, though, that for all the remainder patients who failed to achieve a complete molecular remission, they actually recommended those patients to proceed to transplant. And so, it's kind of interesting that the patient population, it's sort of splitting up into the two groups: those who are destined to do well with less intensive chemotherapy, less toxic chemotherapy, targeted therapy, and mostly, ideally, we would like to see in this role targeted chemotherapy agents, monoclonal antibodies such as blinatumomab with dasatinib or ideally ponatinib. But then the question arises, what do we do about the remainder of the patients, those who are not able to achieve those complete molecular remissions? And even more importantly, so how do we identify them? What can we do to identify them up front so we could treat them more intensively? The groups that are conducting those trials, they are looking at the role of complete molecular remission, of course, and then they are actually looking at the role of CMR and the dynamics of achieving CMR and the role of additional cytogenetic remissions and mutations. And here, Farhad, I think you could probably comment on that as well, as your group looked pretty extensively at the role of mutation, which seems to actually depend on the regimen that is being used.
There are some predictors that was actually shown in the Italian study, including IKZF deletion, and CDK mutations, and patients who did have both of those tended to do worse. This has been shown with other studies looking at Philadelphia positive ALL. I'm not sure if you're ready at that point to actually select these patients for whatever intervention we're going to think about, be it intensive chemo at the beginning or allogeneic stem cell transplant. But yes, there are pre-treatment factors that potentially can select those patients who are less likely to get a long-term durable response. I think complete molecular remission continues to be an important predictor of outcome, and Perhaps we can actually try to supplement that. There are, I mentioned earlier about immunoglobulin heavy chain gene rearrangements and clonoSEQ. Perhaps we can use two assays together to find even deeper remission than complete molecular remission to predict that patient is not going to be relapsing at all.
Rich, would you like
I agree with that. I think the goal is a deep remission with a combination of a tyrosine kinase inhibitor and some minimal therapy. The early use of antibodies is going to be important. There's no reason why those two modalities shouldn't be synergistic. We may be able to have both our cake and eat it too, as there are some interesting studies ongoing using combining tyrosine kinase inhibitors of the typical type with the allosteric tyrosine kinase inhibitor asciminib to see if we can even get deeper remissions that way. Obviously, you alluded to ponatinib plus blinatumomab. Dr. Wiedewelt is doing a study with induction with inotuzumab followed by blinatumomab. That's for non-Philadelphia positive ALL, but obviously one could think about adding a TKI and applying that to Philadelphia positive ALL. So we have a lot of tools, and I think the goal should be to gradually diminish the risk we put people through, at least initially by getting rid of induction chemotherapy and maybe eventually by getting rid of transplant.
I do want to mention very briefly another tool that is not talked about very much, and venetoclax. No, venetoclax is everywhere, but we did a very small study of combining ponatinib and venetoclax in multiply relapsed Ph-positive patients, and it was highly effective. So it is not impossible that in the future, venetoclax will find its way into this arena as well.
Absolutely.
So we started with high-dose chemotherapy, multi-agent chemotherapy, and we added tyrosine kinase inhibitors, and I guess the treatment evolved to minimal intensity, but still cytotoxic chemotherapy as looked and investigated by Italian regimens, Gemma studies. And now we seem to be focusing, appropriately so, on combining the newer monoclonal antibodies and the newer targeted chemotherapy drugs such as venetoclax with TKIs, which will hopefully lead us to the future. Then again, whether those drug combinations will be able to cure all patients with Ph-positive ALL. I suspect that this disease is more heterogeneous, and the more we treat it, the more we realize that it's one size may not fit all, but hopefully majority of the patients would be able to achieve long-term survival and cures with combinations that will be less toxic than hyper-CVAD and TKIs. In conclusion, thank you again for joining us for this segment on the role of chemotherapy in the frontline treatment of Ph-positive ALL. Please be sure to click on the landing page for this activity to claim your CME credit and access the other topic segments on the best TKI for frontline treatment of Ph-positive ALL, the role of allogeneic transplant in Ph-positive ALL, as well as some patient case scenarios. Thank you.